Thank you, Dr. Palafax, for a wonderful presentation. I'm now privileged to introduce Dr. Felicia Knaul from the Miami Institute of the Americas. She's an international health economist and expert in Latin American health systems and social sectors. She's also professor in the University of Miami Department of Public Health Services and the Leonard M. Miller School of Medicine. She recently served as director of the Harvard Global Equality Initiative and associate professor at Harvard Medical School. She's also a member of our planning committee, and we appreciate all of her work in developing this workshop. Dr. Knaul?
Is this working? It's working. Perfect. So I'm too short to stand behind a podium, and we've been sitting for too long. And I decided this would be a little bit better than that. I'm very, very thrilled to be with you here in Washington. And coming from Miami to a little bit of chill was just fine, actually, for a change. I'm going to share with you actually some comments I would have made tomorrow in the last panel, which I was originally planning to be on, and also a little bit of thought around sociocultural barriers and other kinds of barriers to accessing care. A lot of what I'll speak to you about is regarding our experience in breast cancer and in Mexico, but I think that we can draw a number of generalizable lessons. My open statement is that I am biased. I'm a person who lives with breast cancer. I lived and was diagnosed with breast cancer in Mexico. That is how we did it with my husband, and how after working for many years within the Mexican health system, we thought about how living and experiencing breast cancer could be integrated within a health system framework, and the many barriers that many, many women face to being able to do so. The presentation itself, though, goes into the academics of this and the policy making and a little bit of the advocacy. First, I want to ask the question that I decide is actually, I can say the statement, that cancer is different in low and middle income countries. Then I wanted to look at some of the barriers to breast cancer access in Mexico, a country where we actually do have national health insurance, national coverage for treatment. Some of the responses that we've developed, and then a few thoughts about scaling up and refining responses that I probably would have given in that last session, but I'll update it a little bit and do it today since I'm here with you. So first, in low and middle income countries, the opportunity to survive is largely defined by income. Some of you have seen these graphs before. It lines up countries from left to right, low income to high income. It simply has mortality over incidence, which is, I agree, a poor measure, but quite indicative of the opportunity to survive. They're all downward sloping. We could argue a long time about how downward sloping they are, but this is any cancer that can be treated. The most downward sloping line is the one for children's cancers, and that piece of data for Canada I think is extremely telling, that a child diagnosed with ALL in Canada has a 90% chance of survival, and the inverse is true if that child is born in one of the 25 poorest countries in the world. It also means, if we look at these graphs, why is cancer different in developing countries? That we have a lot of opportunity to flatten those lines. And here's what that would mean if we think about breast cancer. We did some calculations with the Mexican Health Foundation that we produced in a book called Closing the Cancer Divide, in which my colleague Afsan Badilia is here and is co-author on that book, and will share, I'm sure, more when she moderates tomorrow. And we looked at avoidable deaths, all of the deaths of all of the cancers. And we came up with numbers like the following, that a very large proportion of breast cancer deaths are considered avoidable with early detection, relatively basic treatment, none of the super fancy stuff, right? But since the majority of deaths actually happen in low and middle income countries, that means that 75 or 80% of breast cancer deaths around the world could be considered avoidable in the way that we applied this kind of analysis. That is a lot of deaths. That makes things very different. We also looked at the inequity of cancer in developing countries and low and middle income countries versus high income countries, and we call that a cancer divide. And it turns out that the way that people suffer cancer in low and middle income countries is in fact relatively different than the average in high-income countries. Not than the poor in high-income countries, as we saw in the last presentation and others, but yes, than the average in high-income countries. The exposure to risk factors, the exposure to infections, treatable cancers, and suffering from those cancers, the stigma and discrimination, which is what we're talking about primarily in this session, because we don't have the same kind of laws and protection, legislation and instruments for women and men and children to hang on to, and the avoidable pain and suffering. I'm going to focus primarily on 4 when I go into some of the barriers, but we could have gone into any one of these. So the way that people live these in low and middle-income countries is different. Now, I think there's also some evidence to suggest the cancer may be different in low and middle income countries. We've done some research on what's behind these pie graphs. Again, it's for breast cancer. And it just shows that a very, very large proportion are below the age of 55, both in terms of diagnosis and in terms of death. And this is despite, obviously, late detection. So you basically see that the pies invert when you're talking about high-income countries versus low-income or Latin America. Now, we are about to release a paper on this. We looked and tortured these data quite a bit, and about 70% of this is due to demographics, right? In low and middle-income countries, populations are younger still. And so you have more young women, you have more young people getting cancer. But there seems to be some other 30% that I can't explain, and I don't think anybody's quite explained yet as to why we're seeing such young women. But so this is another reason why cancer is different. And when we think about early detection strategies, what do we really have to offer to women below the age of 40? And if the majority of our cases are in fact women below the age of 40, is it really mammograms or not mammograms even? We know that that's not the answer, yet we're still fighting about whether or not that is the answer. So all of these points make the work that we do in low and middle income countries different than what we typically do in high income countries, and similar in many cases to what we do in very low income populations. So what are the strategies that we have to apply, and what are the barriers that we need to break down? And now I wanted to share with you some of the research that we've done in Mexico, thinking from a health system perspective and then getting a little bit more granular. So first, if we think about breast cancer again and a care continuum, I think it's one of the more unique cancers and diseases that we can study when we want to think about the chronicity of illness, because it has each of the 6 stages. Right? We're worried about primary prevention, we're worried about early detection, we're worried about diagnosis, treatment, survivorship, and pain control and palliative care. Well, in the case of Mexico, when we analyze the system, we find a system that's pretty exemplary in terms of policy work on risk factors and on treatment, and pretty deficient in terms of earlier detection, survivorship care, and palliative care. Why do I say that we are pretty unusual in terms of treatment access? It's because today, and in fact since 2007, each and every woman diagnosed with breast cancer, and it's not the only cancer, is fully insured for her treatment. And it's a pretty reasonable package. For example, it includes trastuzumab. It's a reasonable package. You can all get access, and I've actually had to successfully, in fact, suggest to patients who are resident in the United States, who are Mexican, that they have a much better deal if they go down to Mexico, and will have a much better likelihood of receiving effective treatment, and we have cases of that. So the treatment is covered, the package is explicit, it's defined by strongly set up policies, it's defined by law, and this is a globally recognized example and an innovation. It's called the Seguro Popular. We have about 50 million people who are on the Seguro Popular. That's like 54, so roughly half of the population that in 2003 didn't have insurance now has insurance that's expanded in the way you see in this graph, both horizontally from poor to rich and vertically in terms of the number of covered services and the diseases that are included. In the case of cancer, this universal coverage is associated with a special fund for catastrophic illness that's expanded over time in this country. It started out including HIV/AIDS-associated cancer, cervical, and only acute lymphoblastic leukemia in children, and it's grown since then. 2007, all pediatric cancers and breast, most recently prostate in 2014. So we don't fully cover all cancers, but it's a growing fund, and just to highlight, it's a fund that's grown despite a country that suffered major challenges, and that's a lesson in and of itself. It grew despite H1N1, it grew despite a tremendous crisis of violence, and it grew despite an economic crisis, a global economic crisis. And that was because there was legislation that protected this reform and allowed for continual expansion, both in terms of beneficiaries and in terms of benefits. So we live in an exemplary country. We live in a country where there are very few barriers in terms of access to care. It's not like when I go to another country in Latin America or the Caribbean and give this talk, and if we diagnose a woman or a child with cancer, I have to worry about how do we pay for the care. I don't have that worry in Mexico, and that's a very big deal. There are a few associated barriers that aren't small, but they're associated with fixing the package: transportation for chemotherapy and radiation therapy, the caregiving and family responsibility issues, which are obviously not small, and I added in the lost income because these men and women are not insured against lost income if they don't have Social Security. So not small ones, but let's put those insurance concerns to one side for a minute. This is what the country looks like for breast cancer. Incredibly unequal. It's the second cause of death in women 30 to 54. Only 5 to 10% of cases are diagnosed in stage 0-1. But the part that I find particularly appalling is the inequities. So in the country where I call home, the north is rich and the south is poor, basically. And within each part, you can look at municipalities. But however you slice up the country, you're about 5 times as likely to be very late detected if you live in a poor municipality than a wealthier municipality. So even if I have all the treatment in the world to offer and it's all covered, if I'm not effectively working on the earlier detection and effective diagnosis aspects, then what I'm doing as a policymaker is I'm over-investing in treatment to some extent. And I'm using that as my tool of action. And this is what we began to look at more and more to say, well, what are the barriers and why is this happening? If I have the treatment relatively solved, why can't I do the other parts? And this is where the story of the barrier starts. So meet Juanita. I met Juanita in a hospital about an hour and a half from the clinic where I was diagnosed in a town called Cuernavaca in Morelos in Mexico. And I walked in to see her receiving the Red Devil, the famous chemotherapy that we all call the Red Devil, in this maternal and child hospital, in a secondary level hospital. And she had all of the barriers intact in her breast cancer. And I actually initially thought that she was mastectomized, but in fact it was because, not a surprising story, the lump was as big as a grapefruit. She had come because she couldn't move her arm from lymphedema eventually, and that's why she finally showed up at her primary care provider to say something seems to be wrong. But the story behind that is incredibly important. So first, she was actually there receiving chemo at this hospital, which wasn't covered by the social insurance program because she couldn't pay the transport and she couldn't leave her children. Why couldn't she leave her children? She'd been abandoned by her partner. That is the typical story I hear over and over. It's why they don't want to go to find out if they have breast cancer. It's why they don't want to have a pap smear, which is not so much the case in Mexico, but in many, many populations to be the case. Over and over, women tell me that they are encouraged, we'll use a nice word, not to do so, by their male partners, and in some cases by their mother-in-laws, let me say. And I'm telling you a story in Mexico, but I also need to tell you that only 2 weeks ago, I was told a horrible story by a woman working at the Miller School of Medicine, that her daughter, 36, who is genetically necessary for her to consider a double mastectomy and did, was then left by her husband with 2 children because she was told that she was no longer useful. That is a story of a woman who lived in Miami, well-educated, a professional, but it goes all the way down the line. The stigma associated with the cancer that we call machismo in Mexico is one of the biggest barriers to any of the work that we're doing on early detection or treatment. And she clearly had that against her. But she had gone through our whole primary care system, and Mexico has an exemplary primary care system, an exemplary anti-poverty program that I'll tell you about in a minute. And she'd been through all of this. We'd done the maternal and health part, we'd done her pap smears, but nobody had said a thing about breast cancer. And the reason was because they figured that breast cancer wasn't a disease of poor women. That's what our programs and policies had used as their way to design themselves. And she was the eventual outcome of this. Now, I know now that we lost Juanita about 2 years after that diagnosis, despite the fact that she had all of the treatment that a good insurance program could give her, but mostly because she arrived too late. Now, what Juanita taught us, though, were many, many things that we were then able to put into a program and into a research protocol, and I thank her for much of what I learned and the rest of the process, and I'll share with you. So we looked at the data on access to mammograms or breast clinical exams, and it's not great. Only 1 in 5 women in the age that should, by the way, we report should in Mexico, had in this study, which is the National Study of Health, a nationally representative sample, had gotten that kind of preventative care. The surprising thing for me was that, yeah, it's lower among the poorest quintile, it's 12%, but it's still pretty bad among the richest 20%. It's only just over 32%. But then we went and asked, well, what's going on in the primary care? And we did one of these qualitative studies to see what were the barriers we were facing, and it was pretty appalling. So 1 in every 2 women diagnosed with breast cancer reported problems with medical attention in the diagnostic process at the primary level of care. Did not receive breast clinical exam or information in their routine annual exam and pap test. The doctor didn't value the importance of the signs and symptoms that were manifested by the woman herself, sent her home without a diagnosis, or more typically with an antibiotic. And the primary care providers themselves, as well as the specialists, said they were very desensitized to the needs of women. We've also, and we're in the field now with this, we're actually looking at survivorship issues among young women with a variety of cancers. But I wanted to share them because I think they speak to some of the barriers in early detection as well. It's why don't young women come in earlier for care in Mexico? And they said things like, I don't have anyone to leave my children with. First are my children because I don't have money to get myself checked. It isn't just any job that gives permissions for absences. That is a major problem. I neglected myself. I didn't get checked because I thought only of work. I never worried about myself. All of these kinds of phrases explain why she didn't get there, even if the care was available. And then when we looked at the survivorship issues, again, I think many of the fears that would prevent women from coming into getting treatment come out. Uncertainty surrounding fertility, body image perception challenges, employment discrimination and its impact, the loss of social networks, unmet primary and psychological care needs. A person with cancer, no one wants to employ them because we're no longer useful. I like to speak the truth when I go to ask for a job, and I tell them, I had cancer and I have to go to an appointment. And they tell me, we don't allow absences. Thanks and see you later. Body image. They always tell me, dress up, make yourself up, do this, and I say, for what? For what now? I've become depressed. Well, not depression, as I told you, sort of a lack of interest. These are the kinds of pieces of information that we're gathering, in fact, in Mexico and a number of cancers and also in Brazil, and we hope to be able to publish once this data collection is completed in the next month or so. But they speak to all of the accumulated barriers that we're seeing among, in this case, particularly young women, but that aren't unique to young women or, in fact, to women. Now, what were some of the responses to reducing these barriers to access in Mexico, applying the lessons learned in developing a program? First I mentioned that at one point we have an exemplary anti-poverty program. It, for a long time, was called Oportunidades. It's changed its name a few times around, but the bottom line is that more than 95%, of poor households are given a supplement to participate in health, education, nutrition, and employment generation as part of a social welfare program. It's a cash transfer program that's focused on women. But it turned out that in these manuals that go to, in this case, 5.8 million families, there wasn't a word about breast cancer. They did have some information on cervical, a few bits of information on other kinds of cancers, but nothing on breast because they said it wasn't a problem of poor women. So we did what we call diagonalizing delivery, and we asked them to include information in an anti-poverty social welfare program for women on this particular disease. We have no way to evaluate it, so I can't tell you how effective it's been, but I can tell you that it's inserted in all of these manuals and all of the information that these women receive. But we had the issue of the primary level of care that we saw from the qualitative data. All of the insensitivities and barriers when women got to a clinic. And so we produced a training manual and scheme for community health workers, both professional associated with primary clinics, but also for community health workers in the community themselves, and then also for nurses and physicians. We worked and have worked and continue to work with the National Institute of Public Health of Mexico, which means that this is a certified program. They get a diploma, so it counts for them in terms of their work in the field, and we work through the Ministries of Health as well as the Social Security. We've now trained more than 16,000 community health workers, professional health workers, nurses, physicians at primary care level, and a smaller group of nursing students and medical students. We do train the trainers for the health promoters, we have print materials, and we have a number of online and interactive courses. We have rigorous evaluation on the education side. The manuals and the didactic materials, I think, are very interesting. They were produced by a colleague of mine, Laura Magana, and they're really designed to reach out to community health workers in a train-the-trainer kind of modality. And we're thrilled to be able to share these with you if any of you are interested. We did the evaluation, as I said, of this in terms of educational uptake, published with my colleague Nancy Keating from the Harvard Medical School in 2014 in the Oncologist. And we were able to show that the train-the-trainer model significantly improved knowledge and comprehension in every group of health promoters, both professional and community, in understanding breast cancer as a health problem, in clinical breast exam, and in learning about breast cancer risk factors, symptoms, family history, and treatment. And we concluded that there was significant potential for involving community health workers in the early detection and management of breast cancer. Those are some of the results that were published. In this case, we're showing professional and community health workers. Particularly interesting that it was the community health workers that showed the most amount of knowledge gained, and there was retention 3 to 6 months after they completed the coursework. We then went on to develop the nurses and physician primary care level training programs as well, and to apply these with more online training. And these are the results for the Mexican Social Security. We've trained just over 10,000 in a relatively short period of time. Those are some of the initial results. I was surprised and interested that it was on the survivorship aspects that they had very little idea of what we were talking about. There's no sort of precedent for the idea that women with cancer will survive to need survivorship care. It's a very foreign concept, yet a very important one to deal with, particularly in this population, which happens to be the Social Security. So that's what we're working on now. Now, some of the more general lessons from all of this that might be useful today and tomorrow, and that come out of what we've been doing in Mexico, and it's about scaling up and refining responses. So, first of all, the reason that I could say that we started out in a very privileged position because everyone was insured and had access to treatment was because there was a health reform. But around the world, there is a wave of health reforms going on around trying to achieve universal health coverage. WHO defines that as prevention, promotion, treatment, rehabilitation, and palliative care without risking economic hardship and impoverishment. So if we can get cancer in low and middle income countries onto the UHC bandwagon, we will have won a lot of ground. If we can scale up our models by inserting them into health reforms, we will very quickly expand. Second is that we have been thinking through, and I think this is some of the most innovative work in health systems, the idea of a diagonal approach. Rather than focusing on either disease-specific vertical or horizontal systemic programs, you harness the synergies between the two. It sounds relatively simple, but in fact, when you go into almost any health ministry, at least in Latin America, you will find an enormous division between those who think about systemic interventions and those who think about disease interventions. And in order to integrate and to harness health reform, you have to think diagonally. Some of the best examples of how to do this are, in fact, around cancer. And you can go beyond health in applying this kind of a health system technology. And that's why I highlighted the second example, which is reducing stigma for women's cancers. Well, it's actually an easier sell when you demonstrate that it's also good for your institute or ministry for women, when it's also good for work that your education ministry is undertaking to ensure equal access for women. And so you get a much bigger, say, bang for your buck by taking advantage of what we can do for something like breast cancer and how that will generate positive externalities, as we call them among the economists, for other programs in other areas. Now, the final point is looking along that continuum of care. That, I think, is some of the most complex parts of this for any health system decision maker and for health reform design. So when you think of health system functions, we typically think of 4: stewardship, financing, delivery, and resource generation. And when you think about a disease that doesn't have a number of stages, it isn't chronic, it's relatively simple. When you think about a cancer, or most NCDs that go along the stages of the continuum, it's a much more complicated graph for your decision maker, and this is it. So your health system decision maker, your designer, has to actually think about 24 quadrants, not 4. They have to consider how they manage stewardship along a whole process of a continuum of disease, or they have to think about a part of that continuum and how it works vertically through the entire health system. And this is substantially more complex. And so we have actually been trying to work, and just published a paper recently with AVSAN in Health Affairs, on how you can help the decision maker to think about this given the complexity of the challenge of chronic illness in which cancer fits in. And I do believe very strongly that this is not too much to ask in low and middle income countries, because I said from the beginning that cancer is different in low and middle income countries because there we are starting so low down in many cases that there are huge and relatively inexpensive ways to move along the curve and flatten those survival lines. And I'll stop with this because this is my personal explanation of why I feel this way and why I believe that doing work on cancer in low and middle income countries is about being an optimist and an optimalist. So we all know that when you have cancer, there are times that are truly dramatic, and this was one of them for me. So I got septicemia in my last infusion in one of our best hospitals in Mexico. And I still recommend that hospital because these things happen, and they say they happen especially if you're married to a physician or a former health minister. You get septicemia directly. It's a direct relationship. So it happened, but the point is that only a week later, and thanks to some wonderful care, I was actually in a butterfly garden in Toronto with our little one, who at that point was 3.5. And I was not very popular bald in public with a 3.5-year-old. For any of you who have gone through this, it isn't easy for children to deal with this. Yet in a butterfly farm, it turns out that bald women with cute hats are very, very popular. So all the butterflies came, all the butterflies sat on my head. And in that moment, I realized that there were actually ways to turn very, very horrible situations into ways of seeing things in a very different manner. And I think that's how we have to think about doing work on cancer in low and middle income countries. And I'm very grateful to all of you in the IOM for producing this opportunity to do so. Thank you.